Now, do eating disorders present differently among males compared to females? Well, here's some of the differences. In anorexia nervosa, there is a loss of sexual interest, there's erectile dysfunction, and there's low testosterone. I'm often asking the males that I work with about their sex drive and about their ability to maintain an erection and to sustain to an orgasm. There's less concern with body weight and a greater concern with leanness and muscle tone. Again, guys typically are not talking about their weight as much as what shirt size, what pant size, how are they able to see the striations of their muscles, etc. Not to say that there aren't plenty who are aware of their weight and talk about their weight, but the number seems to be of less distress. Compulsive exercise is a major component for most males that I work with. And in the research. So this is not just my anecdotal experience, this is what the research says. Bulimia nervosa, there is a preference for high protein and high fat foods as opposed to sweets we often see in women. A difficulty defining a large amount of food and loss of control on the binge. And again, that's very important to recognize. Interestingly, when we see them talk about cheat meals or cheat days, when they talk about it, they recognize this is very much like a binge episode. And you want to think about it that way because it usually comes with, if they didn't undo that binge with a restriction or compulsive exercise, the guilt and shame is really prevalent. Binge eating disorder, again, less likely to be able to describe what a binge looks like, less likely to report distress related to binge eating. And then there's OSPED. I'm assuming most people know the 5 subcategories. And it is, again, the most common eating disorder seen because males, you don't typically get males who meet one of these classic diagnoses because self-report is so difficult to register, plus getting to the very low weight of anorexia, et cetera. And the fact that exercise is such an interesting component of the bulimic experience, that it's to the eating disorder experience, not quite sure where to put that oftentimes. And it's due to the fact that males don't often, again, meet the criteria. This is most commonly where they fall. Now, the anecdotal evidence is that men are more open and comfortable in male-only groups and male-led groups. One of the top researchers in the world on this is Dr. Stuart Murray, who runs a program at USC, who is studying these issues. And what we have to do is make sure that any group treatment where it's mostly women, which it will be, is a welcoming environment. You have to address the differences between males and females in etiology, in language, in treatment goals, and obstacles. You have to create a space where female-centric language is corrected to be gender neutral, because from the website to the handouts to the very therapist saying, all right, ladies, let's go, is so natural to say. We have to learn how to rethink.